All right, so I'm gonna enlarge. Let me see if
I gotcha. Yeah,
are
perfect.
you
You
guys
mind just
able
giving that full
to?
screen?
Yeah, let me take this off. Wait, hold on.
Yep, you're good.
Okay, is it full screen now?
Yep, you're perfect.
Uh,
Okay, excellent. So good evening, everyone. My name is Annie Benzie. I am the committee sub-chair for the SSAT Complex GI Surgery Fellowship. We have a great talk tonight put on by one of our fellows. And I'd also like to say thank you so much to Dr. Maria Altieri. She is actually a second-time moderator for this series over the last 3 years. She is assistant professor of clinical surgery at Penn Medicine, as well as a section chief of GI surgery at Pennsylvania Hospital. So without further ado, Dr. Altieri, can you just give us a little introduction to the topic and then introduce our fellow?
Oh, great. So thank you again so much for having me. I think that endoscopic procedure for primary weight loss surgery is such an important topic at this age. And I see Dr. Gagne is here as well. So welcome, Dr. Gagne. There's a lot of, with the treatments today, with medications and less of trying to get less invasive procedures. There's excitement about endoscopic procedure for primary weight loss. I honestly think that when we think about obesity, we have to think of it as in a comprehensive manner, and we have to all be able to offer our patients not just one choice, but several choices and see what they are interested in. And if not everything works for everyone, there is a lot of, sometimes concerns about procedures and specifically more invasive surgery, which is laparoscopic, which they see as more like, the laparoscopic side. So I think that this is a good alternative and an option for patients who have a lot of concerns. So with no further ado, I just wanted to introduce Juan Rua, who is a fellow at Penn Medicine Princeton Medical Center. And I'm very excited to hear the lecture.
all right. So nice to meet you guys. Juan Rua. I'm a fellow at Princeton. I did medical school at New York Medical College, and I did residency in Orlando. And after this fellowship, I'll be going back to Florida for a job in bariatric surgery. So I'm happy to be here. So I chose this topic because, I think that all of us as bariatric surgeons should be sort of like Dr. Altieri said, well-versed and familiar with everything regarding weight loss, whether or not we provide that, those procedures or not. So at my program specifically, we don't do these procedures, and that's, I guess, ironically why I wanted to talk about it, to sort of be more educated on the topic. And I know that there's a lot of fellows that also don't have a lot of experience with this, but I think we need to be familiar with the topic. No disclosures, not yet. So obesity is, just in general, it's defined as a condition of excessive fat accumulation in the body to the extent that health and well-being are adversely affected. That's a very general, definition, but there is a large amount of variation in what would be considered overweight, and that depends on age, gender, and other variations. But we use BMI. We're all very familiar with the chart for BMI to measure who is considered obese or overweight. So some epidemiology in the US, almost 40% of the adult population is already considered obese, and 1/3 of the world population is overweight. And just to compare, back in 1980, only 5% of women and 8% of 5% of men and 8% of women were obese. So as we can see, that number is significantly increased. And by 2030, it's estimated that about 58% of the world population will be overweight and or obese. It's more prevalent in economically developed nations, and the leading cause of preventable deaths in the US. In 1998, healthcare costs associated with obesity were I have to move this window here, sorry. 78.5 billion, and today is 191 billion. All right. So bariatric surgery. So like I mentioned, 40% of the US population is obese, yet less than 1% of eligible patients undergo surgery. So we're operating on a very small fraction of people who would qualify for these procedures. And, these things in the last 10 or so years, that number hasn't changed very much. So for some reason, we're not getting better at recruiting these numbers. So I don't know if it's a referral bias. People see it as a behavioral problem versus a disease in the primary care world. So, people or they sort of get stuck in that lifestyle modification stage, and primary care providers may try to continue down this route. And as we know that, behavior modification and lifestyle modification it's not very, doesn't help too much. Is it too risky? Are patients, afraid to undergo surgery? Is it payer resistance? So there's a few issues that we could improve on, but that number has not improved. And bariatric surgery, the complication rate is also pretty low. It's under 1%. ASMBS reported about 279,000 bariatric surgeries in 2022. And that's sort of the breakdown of the types of surgeries that we did, with sleeves making up 57%, bypasses 22%, revision 11%, and the rest were the other procedures like BPD, SATs, and also endoscopic procedures. And so I wanted to sort of just touch on the two main surgical procedures before we jump into the endoscopic. But sleeve gastrectomy is the most commonly performed bariatric procedure in the world. It creates a tubular structure by removing about 70% of the stomach. The mechanism of action is obviously you have the restrictive portion, but there's a gut-brain hormone interaction that also helps with weight loss. And expected excess weight loss is about 60 to 65% at 2 years. And at 5 years, as we know, there's a little bit of weight gain, so it's about 45%, and very low 30-day mortality for sleeve gastrectomy. The other common procedure is Roux-en-Y. So it was about 65% back in 2003, but now it's down to about 20% of all the bariatric procedures. And that's because the sleeve kind of fell into favor. So the main thing that, the main components of the procedure are a small proximal gastric pouch where you anastomose it to a Roux limb. And that length can vary depending on provider. You have a BP limb as well, which transports secretions from the gastric remnant, liver, and pancreas. And the idea is to have a small pouch, a narrow GJ anastomosis, and this serves as the point of restriction. And the Roux limb is site of bypass absorption, and the common channel is the site of major absorption. Again, ideal Roux limb and BP limb have not been determined. So if you ask around, I think people have their ideas of what is ideal. And expected weight loss would be 70 to 75% at 2 years and 60% at 5 years. Diet and exercise alone have demonstrated very limited effectiveness of it and poor durability. And still, as of yet, bariatric surgery is currently the best method at durable weight loss. And even among the rise of new medications or these endoscopic procedures that we'll talk about. But so now we have this, endoluminal procedures that are sort of emerging as an alternative to surgery or as a bridge to surgery as well for severely obese. So endoscopic, bariatric, and metabolic therapies, current FDA approved procedures are confined to gastric modalities. So as you'll see, there's sort of two modalities, small bowel and gastric. and the small bowel directed therapies are still considered investigational and not FDA approved, as far as I'm concerned, for most of them. And for the gastric modalities, they include gastric volume reduction by space occupying devices, and that's all basically talking about balloons, essentially. Then you have gastroplasty as well, and there's a few other technologies like aspiration therapy that we can talk about. ASMBS defines efficacious techniques as those that can provide a percent excess weight loss of at least 25% at 12 months with a very low serious adverse event rate. So, that's also up for the debate whether these procedures are going to have long-lasting weight loss. So these are the ones that we'll talk about. So intragastric balloon therapy. So essentially temporary therapy for management of obesity that involves placement of a space occupying balloon. The concept dates back to when DeBakey actually observed weight loss in patients that had gastric bezoars. And it was initially used back in the 80s, but it was discontinued due to complications. So there was erosions, ulcers, obstructions, and the FDA consequently removed it from the market. But currently we do have 3 FDA approved balloons for weight loss. And outside of the US, they're mainly used as bridge therapy to surgery. So these are the 3 balloons. So the Orbera, saline filled, Reshape, which is also saline filled, and Obalon, which is a nitrogen filled balloon, which is pretty interesting. So it's indicated for BMI 30 to 40 in conjunction with all of these, as with any bariatric surgery, is with long-term supervised diet behavior modification. Contraindications are previous gastric surgery, severe gastritis, large hernias, which the number that I've usually seen is greater than 5 centimeters, ulcers, esophageal motility disorders. Obviously, if you have gastric mass, gastric cancer, or any coagulopathies. So this is the Obrera balloon, so single fluid filled balloon. So you fill it with about 400 to 700 mLs of saline, and all of these balloons stay in the stomach for 6 months. So it's placed under conscious sedation or under general anesthesia. So they use a sheath and a guide wire to place the balloon, and all of these procedures, depending on who's placing them, you usually want to do an endoscopy first, a diagnostic endoscopy, and then after the fact to make sure that it's in correct position. And then the balloon is filled under direct visualization. This is
Juan, this is for this one and the Reshape, the 2. Obalon is actually, you can do it while patient is awake. It has a pressure device and a string that is together with a little capsule where the balloon is. And so patients actually swallow it.
Yeah.
The capsule dissolved. Oh, do you have that? I'm sorry. Like
yeah, that's the Obalon, right? Yeah, the gas filled. Yeah.
So that's the difference between the 3. But sorry, go back.
Yeah. So the Obrera is still under sedation, right? Or did I get that?
No, that's true. But
Okay.
I thought that you were talking about all 3 of them. Just wanted to make
Oh,
sure.
no. Yeah. So yeah, this is the Obrera, and then the Reshape. And as far as I know, the Obrera and Reshape are both placed under sedation, right? So, and again, so these are 2 independently inflated, non-communicating balloons. They also stay in the stomach for 6 months, and the placement is similar to the last one, to Obrera. And you do a screening endoscopy and so forth. And the last one is the Obalon, the swallowable gas-filled balloon. So that's the one you were mentioning. So it consists of up to 3 intragastric balloons placed during that 6-month period, and each balloon is filled individually with nitrogen gas. So that one can be done under fluoroscopy without sedation, and the patient swallows the pill that is then connected to a catheter that's then inflated. And there's a pressure gauge basically to determine when the balloon has exited the esophagus so that it's not accidentally inflated while it's in the esophagus.
Also, the
Mhm.
caps, I think the balloon itself has a marker, so it's placed on the fluoroscopy, or you take an X-ray basically.
You can see
So
it.
there's two mechanisms: it's the pressure and also the X-ray to confirm that it's in the right position, and then you actually inflate it.
Okay.
And at the end, there is like a little pressure. I guess like like you just kind of push a button. The pressure takes away the string away from the balloon. The balloons are not inflated at the same time. They're like at like 2 to 3 week intervals, depending also on the patient.
Okay. And it's always done under fluoroscopy. And so you are not always under
No, you just need an X-ray technically.
or X-ray. Okay.
You just need an X-ray. So we did it in the fluoro room, but
Okay. So patient management after balloon. So you should advise patients that there is a certain level of nausea and vomiting, and you could have abdominal pain after placement, but the biggest sort of the most common thing that patients complain of is nausea and vomiting. And there's a low but not absent gastric ulcer rate. 19%, and doctor, I don't know if maybe yours, you have a different experience, but just from the literature, what I read was about 19% early extraction rate because of symptoms. So which could be pretty high. So that's pretty high. So that's something to consider. The diet is progressed to solids in the first couple weeks. Ideally 3 small meals a day, chewing well, avoiding high calorie liquids. So sort of similar things that we would tell our sleeve patients. And after the ideal management is additional 6 months of medical supervision after the balloon is removed. And removal just involves an EGD with puncturing of the balloon with a needle catheter, and then you remove it with a grasper. So these are some studies here showing some outcomes. So Obrera was approved in 2015 after a randomized trial of patients with a BMI of 30 to 40, and they divided those patients between the balloon and lifestyle modifications. So at 6 months, the balloon group, there was a total body weight loss of 10.2 versus 3.3 in the lifestyle modifications. At 6 months, it was 9.1 versus 3.4, and 9 months, 7.6 versus 3.1. So, when you're comparing just lifestyle to the balloon, there was a significant change. I guess the thing that maybe everybody would be more interested in would be comparing, surgical procedures to the endoscopic procedures. And there's a few, but they're not very widespread, these trials. Reshape was approved in 2015, and randomized trials showed a 28% excess weight loss at 24 weeks. And then after 24 weeks, half of the patients had more than 25% of excess weight loss. They remained there. Other adverse events not initially noted in these studies were acute pancreatitis was one of them. So I'm just moving this here. And Obalon, so approved in 2016 after a trial as well, and 6.9% of total body weight loss versus 3.6 in the control group, which was, again, just lifestyle modifications.
now, Juan, there is a question by Dr. Raja. If anybody has had any esophageal lax during removal.
Yes. Yeah. Esophageal lacer upon removal. Yeah. So that's a thing that is talked about. That is one of the, I don't know if complications, but yeah, complications that you can get pharyngeal lacerations or esophageal lacerations upon removal. So
I put in the chat, I had a patient transferred to me with a BMI of like 50 who had had a balloon, like the terriblest patient to have a balloon. And of course, he has a laceration as they try to take the thing out and has a contained perf that I was able to manage conservatively, but it was, like complication upon complication, basically.
Okay. And then obviously, I guess not full thick, just like mucosal injury or.
It actually was a contained perf in the left chest. I mean, it
Okay.
was a full thickness issue, and we were able to manage it conservatively. We actually didn't even stent him because he was totally stable, so we just kept him NPO for a little bit.
Okay.
I'm just curious. I mean, we used to do abalone at Stony Brook, and we haven't had any issues. But I'm just curious for the rest of the surgeons here who do this, Ali Devakoli or Dr. Gagne. Have you experienced such issues?
At our facility, like Dr. Samoy, which is a therapeutic endoscopist, she's the one that also does the bariatric endoscopic procedures. She does do the opera, but I haven't heard any problems from her. Also, it doesn't happen that often because it's usually cash.
Yes, that's what
So
my point too. That it's usually cash.
yeah, so her volumes are not very significant. She also does the endoscopic suturing.
You
But
mean
those are
ESG?
usually no endoscopic sleeves. She
Yeah,
does
usually.
endoscopic sleeves as well. So
Yeah, so usually they're it's about when we did it at Stony Brook, it was about like somewhere between 8,000 to 9,000 depending on the balloon, but most of them were all balloon.
Okay.
Dr. Alteri, I just wanted to also mention one other complication we had was somebody, and I can't remember which balloon this was, but it was inflated in a paraesophageal hernia, and actually the patient lost a stomach.
Oh, wow.
She came to me late with a dead stomach.
So I think that just highlights the importance of an endoscopy prior to doing this.
Dr. Tavakoli?
Yes. Oh, hi everyone. Thanks. So as you probably know, we have a fairly aggressive and big bariatric endoscopy group. And although balloon was certainly part of the stuff they did, we've seen we never really had a large volume, and we do very few of it these days. And when we did them, we fortunately didn't have many complications other than just not great outcomes, I guess. And but I was going to ask the group about, I think with some of the balloons, it was the FDA warning, the black box warning about the hyperinflation as well. Did anyone have any issues with that or ever come across that issue?
We didn't. We don't do them here now, and I think the Philly population, we're actually trying to look into it, but the Philly population can't really afford that much to do the like the balloons out of pocket. It was better when you were right by the Hamptons. It was a higher.
Yeah, I mean the question becomes, if you were going to pay, would you pay for endoscopic sleeve? Would you pay for this, or would you just pay for GLP-1?
Probably ESG. I don't know.
Or just a compounded cheap version of GLP-1? That might be even better.
Go on Groupon.
Right, that's right.
Any other comments? Annie?
Dr. Ula?
Yep. So this was a table, sort of nicely succinct information, describing weight loss with the three different balloons. So here, excess weight loss of 38, this one had, and I don't know if, people would agree with that or if they're seeing that clinically, 27.9% and 25.2%, which is, pretty significant. So gastroplasty is the next thing that I want to talk about, which is a general name that describes various endoscopic procedures to induce restriction. So there was a few different systems, transoral gastroplasty, primary obesity surgery, endoluminal procedure, pose, and then the overstitch. And that's, as far as I'm concerned, the Apollo platform is the only one that's currently sort of FDA approved to do the sleeve gastroplasty. And that's the more common one right now. So the stapling gastroplasty was this toga technique, which is use a full thickness stapler along the lesser curvature of the stomach. And there was 3 main studies that showed about a 24% excess weight loss at 6 months. They did say that many didn't have an intact staple line after some months when they checked back with an endoscope. So, and common adverse effects were pain, vomiting, and dysphagia. There was another system that was abandoned after the pilot study of 7 patients, where 3 resulted in perforations. So all in all, most of the stapling methods of the gastroplasty have been abandoned, and now most are using sutures. So this is the post procedure. So it's similar. So it's plication of the gastric fundus and distal body by full thickness sutures. There was about a 45% excess weight loss. And, you know, they had a study as well comparing pose versus diet and exercise alone, and pose versus a sham procedure, which showed that there was increased weight loss with the procedure. So this is the Apollo system. I think this is the one that people would be more familiar with, the ones that people are using. I was recently in a conference or Ethicon thing in Cincinnati, and there was a patient, a surgeon there that did these procedures, and so we talked a little bit about it, and she does this procedure with the Apollo system. And then this is the one that Dr. Chow mentioned. We have a advanced GI person here that does these procedures, although it's not very common, but she does do them every so often, and she uses the system. So it basically uses suture, so it's full thickness, or the idea of it is to get full thickness suture of the stomach wall, and you plicate along the greater curvature of the stomach, and you start sort of distally and work your way up. So it's thought that besides restriction, there was some literature saying that there's some delayed gastric emptying and decreased ghrelin. I mean, whether or not that's true, it's hard to say. I feel like, to me, it wouldn't make sense that there's decreased ghrelin because you're not excising anything, but there's some theory that there is a decreased ghrelin. Contraindications include large hiatal hernias, ulcers, or prior stomach surgery. The prior stomach surgery, you know, that one is a bit of a, I don't know if it's an actual absolute contraindication, because this system has been used a lot for patients who have weight regain after a sleeve, and you have a dilated sleeve. Because as we know, you can do sleeve, sort of re-sleeve a patient. You know, I don't know how much we're doing that. I haven't done that personally, but so that's the only caveat there. There was a study here where they showed an excess weight loss of 50%, of up to 50% at 6 months follow-up of 112 patients, which is significant. There's
Juan, do you have anything about the merit and the essential trials?
Yeah, so the merit trial, I don't know if I put it here. I might have put it here, but
also with the, you know, the ESG compared to sham.
I have the information.
Also that were showing that the ESG actually did better. And then there was a couple of other studies, at least the last time I was looking at this. There was one by, I think it was Fiorillo, that compared also ESG and sleeve gastrectomy. And they also had a pretty interesting finding that excess weight loss was, I think, like 40% versus for ESG versus sleeve gastrectomy was like 50%, which is pretty comparable. Good result. There was another study, and I can't remember the author of that. That was a little more controversial there. It didn't show as good results. But I don't know if you have any of the.
Yeah, I have it here. I think I mentioned it here, but yeah, the merit was a 2-year. I have the information here. 209 participants. It was a randomized trial, and it was endoscopic sleeve gastrectomy, plus moderate lifestyle modifications versus just lifestyle modifications, and there was an excess weight loss of 49% with the endoscopic sleeve versus 3% in the control group. So yeah, that was significant. That's one of the big trials that they talked about as well. And there was one that compared gastroplasty versus lap sleeve gastrectomy as well. And there was, let me see.
That should be Fiorello, right?
That one was, what was it?
There was a Fiorello one, like they did like a trial where they compared 23 pairs of ESG versus LSG.
Okay.
The one that they were
That was
trying to
this
keep,
one.
like very similar. There was another one that I can't remember the author's name, but
Okay.
one question, and I'm just curious for the other, because I have never had to actually convert a ESG to LSG, and I know that there's an anchor. That first stage is an anchor. Can someone comment if they had to do it, and how did they get out the anchor? Again, Dr. Danier, Dr. Tavakoli. I don't know if you've had some exposure with that. I'm actually very interested because I do want to start doing this. I was trained on them, but that kind of scares me. So,
You were thinking about converting them to laparoscopic or what? Or
so when you have to actually remove the sutures from ESG, you have to convert to LSG. That first stitch is actually an anchor, and it gets buried. And I was actually going to ask Silvana Peretta how she does this in case that ever has to be done.
I'm happy to make a few comments on this. So I have to admit, our GI group has moved away from using the Apollo system and the suturing to the USGI plication technique, where they tend to use this kind of titanium baskets that create plications along the stomach. And they do that because they feel it leads to better weight loss. And most of the patients we actually convert now are those patients, the ones with USGI. And we do not even attempt to do a laparoscopic sleeve in them. All of them get converted to a bypass. And even then, the issue is kind of challenging because sometimes some of the plications are fairly proximal. And for a period of time, they even did this, what I would call an anti-reflux addition to their pose procedure, where they put in some plications right below the GE junction. We've converted several of those to a gastric bypass as well. And, I think it's, the staple line, the stapler positioning really is a combination of feel, judgment, and endoscopic evaluation. We have a paper under review, I think hopefully may be accepted soon, in obesity surgery, with our first series of about just over a handful of these cases being converted to a bypass. And we've had good results. We have 3D CT recons of these cases, and it's kind of remarkable how much metal work there is, and you have to kind of get through them to do the bypass. It is possible, although in some cases we've had to leave plications in what remains the gastric pouch.
Interesting. Ali, do you guys have any videos of that? I'll be really curious to see.
Yeah, we have videos. I think it's may even be part of the paper, but I will happy to share. I think to your point about removing those baskets, so the removing of those is not really feasible. So we've tried working with Chris Thompson and his team to try to have them removed. That's not really feasible. On the on the Apollo suturing, we've done those as well, and they can go and cut the sutures, but removing the ankles per se is not necessarily easy either.
Yeah, that was my question.
Yeah.
So when you're converting these patients to a bypass, you don't remove the sutures from the endoscopic sleeve gastrectomy. You leave it as is.
Yeah, we've tended to leave them because mostly the patients we have with the plication technique with the USGI device, you cannot remove those devices,
Okay.
those baskets.
Gotcha. And you said you just have to be careful that you don't sort of get into the suture.
Yeah, so some of our faculty proposed getting a CT recon of the stomach to help guide assess where the staples lie. In general, I think we've moved away from it because we don't really find it very helpful. But certainly doing an intra-op endoscopy is helpful, and I think, with experience, you kind of get a sense when the staplers may be on some of the baskets, because it's actually hard to see them. Even with laparoscopic and endoscopic assessment combined, it can be sometimes difficult to get a sense exactly where they are. I don't know if others have had experience with that.
Ali, can you not just transect the stomach? Just cut it open and just do nothing?
You can do the stomach, open the stomach and do.
I mean, when you convert into a bypass, can you not just transect the stomach and therefore you can see everything, right? And just do a hand sewn GJ.
I guess the challenge is where to transect the stomach. So the anastomosis is usually less of an issue, but is the transection of the pouch usually, because the plications or these titanium baskets are along that area.
Yeah, but once you have the stomach open, you can see it, right? So no?
I'm not sure I can, I'm struggling to imagine that. So you would make a gastrotomy, you're saying?
So sometimes, what I'll do for redo situation is just cut across the fundus of the stomach where I'm planning to do my GJ for the Roux Y, and you'll be staring at the inside of the stomach, and you can decide where to cut depending on your devices and things. And then
Oh,
just
I
do
see.
your anastomosis to the proximal and just oversew the distal.
I have to think about that. We have not done that. I'm not,
Yeah.
yeah, I haven't really, may need to use a little bit of thinking about that one, but I haven't done that, to be honest. Maybe a good idea.
I may just not be smart enough, Ali.
No, I think it may be too smart. I may need a picture to understand what you're saying. I need a coloring book.
I'm sure he'll be happy to draw you an illustration, actually. When we actually, when Dr. Jayaj, we had a couple of patients that have VBGs that we were taking down, and that was actually not with the band inside too, like someone actually had taken the banding part out, and that's kind of what was the most helpful, I think too. It's just you can see everything on the inside. It was cool, scary, but cool. But anyway, Dr. Rua?
I just don't know if you can see that anchor. That's the thing.
Maybe, but maybe if you put your hand in there, you can see where that tissue like ends. You know what I'm saying? I don't know.
Because you can cut the suture, but it's the
Metal part. Yeah. Interesting.
So, I don't know.
So for these, I sort of added this for completeness sake, but these are not FDA approved. And some of them seem, I don't know, interesting. So the transpyloric shuttle, so there's a balloon that basically sits in the pylorus, and they've done some trials with patients, and it showed up to 50% excess weight loss, but 2 out of 20 were removed for ulcers. Then upon removal of the device, 50% of them had antral ulcers. So there's apparently a prospective sham trial underway, and it causes intermittent obstruction. So seems like it would cause a lot of symptoms, I would imagine. Full sense device was another one where it's a conical component that presses against the cardia and induces satiety. There's no published data yet, no peer review data. But apparently there was this report that is unpublished, so I don't know how much we can trust it, and they reported 80% excess weight loss. Again, these are not FDA approved. This one I found interesting, gastric aspiration therapy. It's essentially a modified peg tube that's connected to a device where you instill fluid and aspirate gastric contents. They did a randomized trial of 207 patients, lifestyle changes only versus gastric aspiration with lifestyle changes. And there was a significant, I guess, difference in the weight loss, as you see there. Adverse events, granulation tissue pain and infection at the site of this peg tube, just like you would see with any other peg tube. And obviously, the first thing that sort of popped into my mind was patients with bulimia and things like that. So I think there's a potential for sort of using it for the wrong thing. But so contraindications are eating disorders, prior abdominal surgery, and functional disorders of the stomach. And I sort of had a hard time believing that patients would want to do this, to be honest. Most patients would not want a tube coming out of their abdomen, but this is something that's out there as well. There's a couple small bowel modalities. Again, these are not FDA approved, but just to sort of talk about them. One is called Valen TX endoluminal bypass device, and it's essentially a barrier, and it goes all the way from the gastroesophageal junction to the proximal jejunum. But if the idea is to not have surgery, then this sort of defeats the purposes because it requires endoscopy and laparoscopy to place a device. And in addition to that, then there's dissection of the GE junction as well. And then you have to reapproximate the crura to afterwards. So it seems very involved to me. There was 5 out of 22 that required early explantation for dysphagia, and there was an excess weight loss of 35%. So, and again, a lot of these things you're going to remove them. So the question becomes, the long-term weight loss, is it going to be significant, or you're going to have a lot of weight regain? This one was similar as well. It's called the endo barrier, and it's a Teflon coated sleeve, and it's anchored to the duodenal bulb, from the duodenal bulb, excuse me, to the proximal jejunum. So similar to the other one, it just starts from duodenum to jejunum, and it just prevents absorption. There was a trial with 12 patients and adverse events. There was, early explantation, abdominal pain, pharyngeal tears, like we had mentioned with the balloons, and inflammatory changes in the duodenum from that anchor. They saw an excess weight loss at 12 weeks of 23%. I mean, pretty moderate. And again, you're removing a device, so you have to think about the long-term weight regain. So they also noted that there wasn't any difference in the hemoglobin A1C. There was a trial that had to be stopped early because of hepatic abscesses, and there was a high early removal rate. And there was basically all the places that were using this worldwide, 1,056 patients, which is a lot, actually, that I was surprised by that. 33 out of those had severe complications, and those included esophageal perforations, duodenal bulb perforations, pancreatitis, cholecystitis, hemorrhage, and hepatic abscesses. And that one is not FDA approved. So it had a high complication rate with very moderate weight loss. This one is pretty interesting. So it's also a bypass, a small bowel bypass, but it uses magnets. And what it does is that it creates fistulas. They demonstrated in porcine model and small human studies as well. There was a study with 10 patients with a BMI of 41 that used enteroscopy and colonoscopy to deploy 2 magnets, essentially, in the jejunum and ileum, and laparoscopy. So that's sort of the other downfall of this, is it requires laparoscopy. to verify the position and attach the magnets. And all of those patients had a successful creation of anastomosis with an excess weight loss of 28% at 6 months, not FDA approved as well. And the last thing that I'll mention here is duodenal mucosal surfacing. So this one is the only one that's being developed specifically as a metabolic procedure. So it's not a weight loss procedure. And it involves remodeling of the duodenal mucosa, which has been implicated in diabetes. So, and that's one of the mechanisms of the sort of Roux-en-Y bypass, gastric bypass. So it uses the Revita system, and you inject the submucosa of the duodenum, and it's from the ampulla of Vater all the way to the ligament of Treitz. And you do a circumferential mucosal lift and thermal ablation of that mucosa. So there's a phase 1 study that included 39 patients with diabetes mellitus type 2 with that range of hemoglobin A1C, 7.5 to 12. Only an oral antihyperglycemic, so patients that were on insulin were excluded. And there was a reduction in the hemoglobin A1C at 6 months, and it was significant. And very modest weight reduction, which was, again, not the point of this procedure. Out of those 39 patients, there's 3 patients that had duodenal stenosis. And there's an international trial currently being done for this. So that one I found interesting, especially because it wasn't attempting it wasn't a weight loss procedure. So these, like I mentioned before, we don't really do these procedures. There's a gastroenterologist at my program that every so often will do them, but it's far and few in between. So this one was a 38-year-old female with hypertension, sleep apnea, and diabetes, and a history of a sleeve gastrectomy, and she had weight regain. So I put this one, I wanted to talk about it because it was interesting that, so she ended up with an endoscopic sleeve gastroplasty. So she used the Apollo system to do the procedure. And at 1 month follow-up, the patient had 20-pound weight loss, and 2.5 months, there was a 30-pound weight loss. But if you notice here, she was also on Zepbound. So, I don't know how much of that was related to the procedure or not. But the patient was on Zepbound the entire time, 7.5 milligrams. So that was sort of higher end of the dosage there. And the other one was 34-year-old male. So this one was interesting because it seemed like he lost quite a bit of weight. He had a BMI of 33. He was 273 pounds. And they did an endoscopic sleeve gastrectomy. And this one was on a virgin stomach. And the follow-up in 1 month, he had lost 31 pounds. And at 6 months, and this was all done again through chart review of these patients. According to the chart, there was a weight loss of 83 pounds. But interestingly enough, all the follow-ups were virtual. So, you can take that, I guess, with a grain of salt. But so the most common of the endoscopic bariatric procedures, and I think the one that's maybe getting a little bit of traction, is the endoscopic sleeve gastroplasty. Serious adverse events were pretty low, and this was from the MERIT trial. 2.26, there wasn't any mortality. There's bleeding, perigastric fluid collection, and yeah, which, all these complications I think can be treated just as you would, if you had a sleeve with a leak, for example. I think we talked about if you're going to do surgery on these patients or you're going to re-sleeve these patients, then you want to try and remove the sutures. But I guess we mentioned that it might be difficult to remove that initial anchoring suture. And the durability of the effects is the biggest concern right now for the procedure, because there's some evidence that these sutures sort of fall apart, or I don't know if fall apart is the right word, but open up. And a lot of these endoscopies months after show that the stomach is back to its normal size. So some take-home points that I wanted to sort of mention is that, you know, whether or not we provide the services, I think as bariatric surgeons, we need to be aware of all this emergent technology. And I think, I don't know, if, as an ethical question, if you don't believe in the procedure, should you as a bariatric surgeon sort of think about learning these procedures? Because if it's not you, there are, you know, gastroenterologists who will be doing these procedures, but I don't know if, I don't know what everybody thinks about that. If you're not a believer in the procedure, you know, should you not offer it to your patients, or should you learn it and have that in your sort of armamentarium, as they say, to give your patients the options? Because patients are coming in asking for what they want. They've done their research and they have their specific thing that they want. When I spoke to the surgeon at this conference that I was in, and when I spoke to the gastroenterologist at my program, I was asking them, what, you know, what kind of patients are you seeing? Is it patients that can't undergo surgery? Are you doing it as a sort of stepping stone into surgery? And most of the time, it was just patients that didn't want surgery. So it wasn't necessarily patients that couldn't have surgery. They had their plan already, and the patients came in and said, I'm scared of surgery, or I don't want to do surgery, I want to do this. So it's just interesting to think about that, you know, even if you don't believe in this procedure, and I feel like a lot of surgeons don't, should you be well versed and maybe learn how to do this procedure, because somebody's gonna do it. So anyway, I think we should strive to be experts in the field of weight loss, whether it's medical, whether it's surgical, whether it's endoscopic, and whether we perform it or not. So if we decide that we're not going to do that procedure, we should know some things about it. We can also use these procedures as bridge therapy. If we don't believe in it strongly for a primary procedure for weight loss, it can be used as bridge therapy for these higher BMI patients, just like we do with medications. I think at the end of the day, currently as it stands, bariatric surgery is still the most powerful tool for weight loss in patients that meet criteria. And you know, it also remains to be one of the safest general surgery procedures. So even when you compare mortality and morbidity with procedures like a laparoscopic cholecystectomy, a sleeve gastrectomy has lower complications. So I think that's something else to keep in mind. The other thing is that a lot of these procedures are temporary in nature. A lot of these are devices that have to be removed, and then, you know, the patient is sort of left to their own devices. And, you know, a lot of them are able to keep the weight off, but a lot of them are not. So that's something to sort of advise your patients on. There's also this, I think, misconception of safety with surgery and these other less invasive procedures, but I think it's important to sort of reiterate that less invasive does not mean non-invasive. So endoscopic procedures, it's still a procedure, and I feel like these procedures are getting more more invasive in a way. So there's still endoscopic procedures, but you're suturing, you're doing full thickness sutures. So these risks that were once reserved for surgery can still show up in these procedures. Like we talked about perforations or abscesses. So you end up getting into that territory where the risks of the endoscopic procedures are similar to the surgical ones. So again, something to just keep in mind. And then the long-term effects and long-term weight regain is largely unknown, or not unknown, but not completely known, because we don't have the years of following these patients. And then the effect on revisional surgery. If these patients end up becoming, and I think we touched on that as well, does it make it more difficult Does it make it more dangerous, more risks when we have to revise these procedures? So those are the main points that I wanted to touch on, and that's it.
Thank you. This was an excellent overview of some of the emerging technologies and techniques. And actually, we have an expert here in magnets, Dr. Danier. I was hoping that he can say a couple of words about his work on magnets and where is that standing as of now.
Well, this is my competitor, so I'm not gonna discuss it. But we've published and presented several papers on it. One was published in the clinical series in surgical endoscopy, another one in SWORD. There's some animal series that were published, but it remains still experimental. We don't have any, long-term weight loss after 1 year. Most of the procedures that have been done with magnets have been like duodenal between side to side, between the duodenum and the ileum, mostly around 250 centimeter or 300 centimeter from the ileocecal valve. And so it creates a bipartition. It's not as much weight loss as if it was a complete CD where you have an end to side, but it can be, in my opinion, for the future, something that could be done without enterotomies and a short laparoscopy. It might appeal to some patients and decrease the magnitude of the surgical stress. But it remains to see, in the longer term, if this will be part of the armamentarium. We need more patients. We need more multi-center studies, and there's going to be variants. The magnets are only starting, and then the interesting thing is to go between the stomach and the small bowel and the colon and all different types of anastomosis in the near future. Our staples and sutures, they're pretty good, but we still have a small percentage of bleeding. We still have a small percentage of leaks.
Well, that's a really exciting work that you guys are doing. So
Yeah.
it would be great to see where that leads.
Thanks.
Any other comments or questions? I want to be mindful of everybody's time since it's coming up on the hour, but one great job. Before I open up for questions, I just wanted to just comment on one thing, which I think is very important. Important point here that if you don't do this, if you don't get some of these techniques under your armamentarium, gastroenterologists can potentially do it. And I truly believe that we do a better job in terms of following the patients, getting them into a multidisciplinary care rather than just doing the procedure and then just like they're on their own. But that follow-up is so important. And I think that that's where we should still keep those patients for us. And there's a lot of patients that will come in and they'll be like, I'm interested in ESG specifically. First of all, ESGs and all the balloons were 30 to 40. I think asparagus was up to 50 now, BMI 50. All the other ones are kind of limited. Once they hear that, hey, by the way, this is not covered by insurance and you have to pay out of pocket, most of them started like wondering about what else is available out there, which I think is also another option of why you should have everything under your armamentarium. So with that, I will open up for any questions. I know we're like 6 o'clock, so I don't want to hold everybody, but.
Excellent. Yes, Jayasha, everyone, go ahead.
Yeah, I just wanted to comment. I just love the fact that in so many areas of surgery, we're becoming so multi-D. And I think it's amazing because I think for us all to learn from each other is really great. And I think, Juan, I just want to applaud you because I think you really summed this up beautifully in that we shouldn't be threatened, right? We should all just work together because there's some patients that do better with X and others that do better with Y. There will always be a role for surgery, right? It's kind of like when I was a resident back in 1922, axillary dissection was like, nobody's ever going to do this again. And now there are more mastectomies than ever, right? As we know about more, genetic mutations, etc. So I just applaud you because I think the multi-D aspect and being collegial is so critical to all of this. And thank you for that.
Thank you guys for being here. And thanks, Dr. Altieri, for moderating.
Excellent. Yep. Thank you both. And thank you everyone here. If you wouldn't mind just putting your cameras on for a second so I can take our screenshot for Twitter. And just like to welcome you all back next month, April 15th. We also have a very interesting topic. It's the use of indocyanine green or firefly in surgery. So just give me 1 second and I'll let you know when to smile. Okay, 1, 2, 3. Excellent. Perfect. Thank you all so much and have a great night, okay? Take care.
Thank you.
Have a good night.